nice weekend? Yeah. Excellent. Okay, so if you look at the schedule, we're cooking along at a pretty good pace. And we're going to be covering nervous system disorders today. There were two pre-quizzes and there's 2 post-quizzes due on Friday. And there's a lot of material on nervous system disorders, so we kind of broke things out to give you a little bit more practice on the quiz side of things. Okay? Any questions? I posted a link to the Flagstaff Festival Science Lecture. That's not testable material, it's just more for public consumption. Okay, so if you're interested in listening to that lecture, it was on the 28th of September. It's there for you to peruse. It's, in all, it's maybe 20, 25 minutes long. That's about it. Okay? All right, first up. Why did the man freeze his money? Why did the man freeze his money? He wanted cold, hard cash. Nicely done. What type of dance do teachers like best? Don't worry, I won't show you. Attendance. Okay. All right, last one. What kind of nut doesn't have a shell? What kind of nut doesn't have a shell? Coconut? Walnut? Are you just going to go show the nuts? A donut. All right, slow start. You guys had a slow start. We got 1 out of 3. That's 33.3%. That's not too bad, I guess. Okay, so today we have a lot to cover. This is on nervous system disorders. And I'm going to start out with a little story. I actually was checking my phone, and the only reason that I might have to answer my phone, or I'll be peeking at it, is my daughter actually had a mild concussion this weekend, as chances would have it. So we were at a soccer tournament. This is my youngest daughter. My youngest and my oldest play soccer. Actually, 3 out of my 4 play soccer. But anyways, this is the youngest daughter. Soccer tournament down in Ahwatukee, and she took a ball to the temple, and she was displaying all the classic signs of concussion. So she was kind of, confused, and she wasn't herself. She wasn't acting like herself, and she's actually a pretty aggressive player. She's fun size, that's what we call it in my house. She's small, and but she's small and mighty, and so I held her out for the rest of that game, put her into the next game. She said she wanted to play, but played her very, very light and only subbed her in to give other teammates a rest. And she was slow, and she wasn't aggressive, and she was kind of, this isn't her, but she was kind of standing on the field, kind of looking over at the side, and every now and then she'd stare over here. And classic signs of mild concussion. Okay? If it's anybody else's kid, they wouldn't have played the rest of the tournament. But she really wanted to play. So got her a good night's sleep, gave her some anti-inflammatories that night, tried to see if there's any swelling to reduce the swelling. And we put food and water on very, very slowly. Usually the telltale sign of a first level concussion is if the individual vomits. So a lot of times there's vomiting that takes place. No vomiting, so I felt like that was a pretty good sign. Gave her a little Gatorade, no vomiting, she held that down. Gave her a little bit of a power bar, she held that down. And then like 2 hours later, she's like, I'm hungry, Dad. I'm like, what do you want? She said, I want a cheeseburger. I'm like, okay, I'll try a cheeseburger. She held that down, so that was a good sign. But so she's back at school this morning, and she has headaches off and on, so it's pretty common. And so I texted my wife and asked if school had called, and she went to the nurse's office and said her head was hurting, but nothing today, so that's good. But kind of timely, we're going to talk about concussion at the end of today. We're going to compare and contrast that to like contusions and hemorrhage. Okay, concussion is definitely at the mild level, but it's not something to take lightly in any contact sport. And so there's lots of newer data. At this level, at youth soccer, at least for girls, because that's all I pay attention to, They're not allowed to head the ball until they're 16 now. So there's no heading until you're 16, which is kind of interesting. So they've delayed things pretty significantly. Soccer's changing a lot. And now a lot of the kids that play soccer, club soccer, have headgear. So they have almost like a miniature helmet across the front of their head, because there's just a lot of head injuries that they smack each other's head. This was a ball in the head, so I'm not even sure the little band would have helped. But anyways, so that's what's going on. That is not my wife, so we're good. So I'm a little distracted today, but it's actually very relevant to what we're talking about. But before we dive into concussions, which is kind of towards the end, we're going to talk a little bit of review. So we're going to talk about neurons. We're going to talk about, I want to do this here. We're going to talk about neurons, and we're going to go back to 201. Okay, so we've got neurons and glial cells. So neurons are the cells, if you remember, that transmit the electrical potential. And they're outnumbered about 10 to 1 by the glial cells, the supporting cells. And these glial cells in the central nervous system, which comprises the brain and the spinal cord, fall into 4 different categories. We've got oligodendrocytes, astrocytes, microglial cells, and epidermal cells. And then in the peripheral nervous system, that's outside of the brain and spinal cord, we just have 2 different types. We've got the satellite cells and the Schwann cells. So this is all review. But I want to go through this because, we have a lot of examples today. Okay, not just my daughter. Actually, we'll talk about my mom. Okay, we'll talk about Muhammad Ali. We're going to talk about John McCain here briefly. And this is a precursor to where we're headed in the cancer lecture, right? So we're going to foreshadow a little bit about some of the things that we see today and we talk about today as we get towards cancer. And so we'll roll that into the cancer lecture. But today with nervous system disorders, obviously brain cancer or tumors are kind of one of the premier problems that we wrestle with or that we see. And John McCain passed away from a what? Anybody know? Brain tumor. Okay. You all can do better than that. That's what the newspapers call it. Come on. What's that? It was a glioblastoma. Thank you. It's a cancer of what cell type, do you think? A glial cell. Okay? So they're very prevalent in the nervous system. So that's what a glioblastoma is. It's a cancer or a mutated cell that's the supporting cell, the glial cell. So in the upper left is a picture of an astrocyte. And many of these glioblastomas involve those astrocytes. And you can see they look like these spider-like projections or these starfish or octopus-like projections. And so if they mutate, those glioblastomas are very difficult to surgically remove because of all of the branching, right? You literally have to come in and surgically cut out every little piece. And that's hard to do, especially in the brain, where you don't want to take too much healthy margin and risk compromising healthy normal tissue that does something important. Okay? Upper left, astrocyte. But they normally are responsible for transporting nutrients from the nerve back to the vascular supply of the brain. Another reason why glioblastomas that involve astrocytes are very dangerous is they have a very quick access to a vascular network which they can metastasize through. Right? That means they can break off and go somewhere else. Upper right. Upper right is a oligodendrocyte, or a group of oligodendrocytes. There's 4 of them there. And these oligodendrocytes help produce the myelin in the central nervous system. So that creates the insulation around the nerve to facilitate faster action potential. And then if we go to the lower left, those are microglial cells. And you see these as really the phagocytic cells of the central nervous system. So they're like baby macrophages, microglial cells, lower left. They kind of move in when you have a damaged piece of tissue in the nervous system, in the central nervous system. And they're what's responsible for some of the scar formation that happens post-stroke or post-damage to the brain. So if a patient has a stroke and there's going to be scar tissue, like what we see with heart tissue or with skin, it's the microglial cells that are responsible for that. They act like macrophages. And then the lower right picture, those are ependymal cells. They line the ventricular system and they give rise to the choroid plexus. And if you remember, the choroid plexus is a terminal point from a vascular supply to a membrane that filters the blood and helps to create cerebral spinal fluid. So you have a choroid plexus in every single one of the ventricles, right? The lateral ventricles and the third and fourth ventricle, you have a choroid plexus that makes that cerebral spinal fluid. You guys remember that? So I know this is a ways back. We're going back to 201. On my YouTube site, those old 201 lectures are still there. And you can go and you can look to see if there's a lecture that you want to review, because maybe it's a little bit rusty. Okay, so those 201, they never took them down, they're still up there. So, central nervous system, 4 types. Peripheral nervous system. We only have 2 types. We have satellite cells and we have Schwann cells. The satellite cells are like the oligodendrocytes, and they produce the myelin in the peripheral nervous system. Peripheral nervous system is just outside the brain and spinal cord, so that would be the nerves that run down to the bottom of your foot, okay, out into your hands, your arm, your trunk, back, anywhere that's outside of the brain and the spinal cord. And then the Schwann cells, did I already say Schwann cells? Similar to oligodendrocytes? Satellite cells, the satellite cells are very much like the astrocytes. So they actually perform this nutritional supplementation where they regulate the chemical environment, okay, of the nerve. They're kind of paying attention to how is that nerve doing. Does it need additional perfusion, nutrition, or are there waste products that need to be moved away? Okay, so now if we look at the synapse, just to remind ourselves, right, the synapse is basically this connection from one nerve to another. There's a gap there. We talked a little bit about this when we talked about the neuromuscular junction in the last lecture. We talked about myasthenia gravis. Do you guys remember that, the muscle weakening? So in this particular synapse, we're actually just looking at from really one nerve to another instead of a nerve to a muscle. So we're going one nerve to the other nerve, and here is the synaptic cleft. And at the terminal endpoint of this synaptic, before you get to the synaptic cleft, we actually have these vesicles that have these neurotransmitters that cross. So this is a blow-up diagram of this box right here. One nerve innervating onto a second nerve, and this is the higher magnification view. So again, if you want to brush up on the neuromuscular junction and the synapses, you can go to my old 201 lectures and just go to peripheral nervous system and central nervous system. If we look at these two systems, just to compare and contrast, we already kind of talked about the central nervous system is the brain and the spinal cord. And then over in the periphery, it's much, much more diverse, right? We have a sensory and a motor division. And then we go and we further break down into visceral and somatic, right? And somatic are going to be cells that are responsible for like body functions, and visceral is going to be more in the abdomen and the thoracic area. And then we break down visceral motor into sympathetic and parasympathetic. And who can remind us, sympathetic does what? What is sympathetic responsible for?
Fight or flight.
Fight or flight. So give me some examples. If the sympathetic nervous system is ramped up, you're going to see heart rate do what? It's going to go up. What about respirations? They're going to go up. What about basal metabolic rate? Basal metabolic rate will go up. Okay, parasympathetic response. Just the opposite, right? All those things decrease. Okay, so rest and digest is the nomenclature for parasympathetic activity where things are slowing down. Okay? If we look at a quick review of the brain, bless you, we see that it was compartmentalized into these different lobes. As it's compartmentalized into these different lobes, we see different types of functionalities associated with where you are in the brain. And so you can kind of appreciate this blue color, right? This is the posterior aspect of the brain. Here's the anterior aspect of the brain. So on your right is the back, and on your left is the front. Here's our cerebellum. And we've got our central sulcus that kind of carves out the frontal lobe, right? From which lobes? Back here. Parietal, and then all the way back here, occipital, okay? And in the post-central gyrus area, we've got our area for sensory, right? That's input from our surroundings. And then just in the anterior portion of the central sulcus, we have our precentral sulcus, and that's our motor function. And so if you were in my class in the past, or if you watch these lectures, the very simplest way to look at this is we get input that comes from the periphery, and it usually comes in the posterior aspect of the brain, and it moves forward to the anterior aspect, and then the motor functions and your decisions happen on the front. So input comes in the back, and as the signal moves through the brain, you process it, and then your decision comes out of the frontal cortex of what you're going to do with that information. Okay? So that's kind of one of the axes of organization of the brain. Why are we doing this? Why is this important? Well, some of the clinical manifestations of, say, a brain tumor, without any imaging, you might be able to discern what part of the brain is being affected. Does that make sense? So nowadays, and as you move into medicine, everything's going to be about taking pictures. But there were times where we couldn't get adequate pictures of the brain. We couldn't see some of the images that I'm going to show you. And so understanding how the brain was organized and understanding what the clinical problems or the clinical sequela was, physicians could actually figure out pretty accurately where the problem, where the lesion was, where the tumor was, where the stroke was, or where the tumor, or where the event was taking place in the brain, simply by paying attention to behaviors. Does that make sense? So let me explain. Back of the brain, okay, there's an area right here known as Wernicke's area, right? Wernicke's area is sensory because it's towards the posterior aspect. So a lesion or damage or trauma to the posterior aspect is going to affect speech, right? It's going to affect the understanding of speech, okay? Understanding what I'm saying, the input of what the words mean. And then over here towards the frontal lobe, or in the frontal lobe, is Broca's area. This is motor speech. So this is sensory speech towards the back, motor speech towards the front. So it fits that organizational structure I just described. You with me? So trauma to the frontal lobe in this area, or a tumor or a lesion in the frontal lobe of this area, which is pretty close to where my daughter got smacked, okay, is going to be motor speech, the ability to articulate. And this happens to be on the left side of the brain, which is the exact area that she got hit, right, 2 days ago. So I was asking her questions to see if she understood me, and I was listening to her answers to see if they were clear. Right? So if you've ever had head trauma, you're seeing stars, they come out and they ask you what's your name? Where are you? Right? What's your birthday? Yeah. What day is it? Right? What year are we in? They're trying to understand comprehension, right? I mean, you could probably give this lecture, right, Alex? They're trying to ask questions to understand if you comprehend what's being said and if you can actually articulate back an answer. Okay? And my daughter did great. Everything was fine. Okay? She was kind of being a little goofy, but the words weren't slurred. She wasn't stuttering. She knew where she was. Okay? She wanted to go back into the game because we were losing. Okay? We ended up winning that game in case for what it's worth. Not that I'm competitive, but she is. So you can look at the map of the brain and you can kind of understand, all right, if I have trauma or if I have injury or if I have a lesion in a certain area, I might be able to figure out where that problem is simply by understanding the map of the brain. So it's not just professors being mean to you. And if you go into medicine and you go into neurophys, you're gonna really appreciate the elegancy of this map and the intricacy of how things are organized. Okay, we're not going to get into that level of detail. I just want to be able to give you a snapshot so you can appreciate why we study some of these things. Okay, want to bet? I might ask a question about a specific part of the brain or a lobe or a region that has a tumor and ask you what might be happening, or here's what's happening, where do you think the tumor is? That might happen upon the exam. Make sense? Okay. All right, so this is still all review. Like technically, that whole slide, this came right out of my 201 lecture deck. So that's not really new information. I'm just spinning it in a new direction, right? With a 9-year-old head injury on the soccer field. Because that was fresh this weekend. Okay? So here's another one. The meninges and the ventricles. So the brain itself, and we talk about this in 201, you guys probably remember this, but the brain itself is infiltrated or infused, and it's essentially floating in a physiologic fluid, and that's the cerebral spinal fluid. It's not blood. It's most similar to blood plasma. It's filtered blood, and the ventricle system essentially manufactures that fluid and perfuses the inside of the brain down the central canal of the spinal cord and then up through the meningeal layer and recirculates it, puts it back into the venous supply. And the meninges are the different coverings that take place on the very superficial most part of the brain, right? So if you remember, we've got our bone here, which is our periosteum, right? And then we've got the epidural space, right? We've got our, let's see, where are we? I'm trying to get organized. Okay, so here we go. Here's our subarachnoid space. Subarachnoid space is where that fluid actually comes back in and circulates through. Here's our arachnoid layer, right? And we've got our dura, and then we've got the epidural layer on top, right? The superficial most part. And in between each one of those layers, we have a little bit of a space. But these are the protective coverings of the brain that's underneath the skull cap. And so we're going to talk about cerebral spinal fluid and when it causes problems known as hydrocephalus. All right, I have a case study that we'll look at that I've been following for years, and unfortunately it doesn't have a great conclusion, but I think you guys will appreciate how it relates to this topic, and that we did prolong the clinical case and had some quality of life along the way. And then if we look at the central nervous system again, and we look through the spinal cord, these are just slices that come through the spinal cord as we move from the cranial portion towards the caudal portion. So cranial means head, caudal means tail. So another specialization of the brain isn't just back to front, but there's also this top to bottom, okay? What we call cranial to rostral. And cranial meaning head, or towards the top, or cephalic, and rostral meaning tail, towards the back, or the bottom. And again, if we're top to bottom, you got to think of us, on 4 legs. So then it's head to tail. So our tail would be here. So as you go from top to bottom in the brain, you see lower down in the central nervous system are more autonomic functions. Things that happen automatically, like breathing, heart rate, okay, bladder control. Those of you that potty train, love the day that it becomes automatic, right? And then as you move towards the top part of the brain, you get higher order thinking. You have personality. You have reasoning. Okay? You have higher functions like mathematics and language. You have the ability for artistic creation. Okay? science, your personality, who you are, your intellect, all captured within the frontal cortex at the top part of the brain. And then we won't talk about it much today, but there's right and left side, right? Right and left side. So let's just go ahead and cover the whole thing. So there's basically 3 axes, right? There's back to front, there's top to bottom, and then there's right to left. And we know from motor function, and that's why this is important, I just want to finish it out. From a motor function, if I, in the precentral gyrus, I suffer a stroke of the motor cortex, what side of the body is going to be affected from motor function? The right side. So if I have a stroke in the precentral gyrus on the motor side, I might have a stroke where now the right arm is constantly like this. There might be a limp on the right leg because the lesion or the stroke or maybe even the tumor happened on the left side of the brain. So that's the right to left hemispheric division. Make sense? So those are 3. Back to front, top to bottom, right to left. And with that information, you can almost kind of pinpoint where you are in the brain and where the problem is. Okay? Another one would be patient has, stroke on the right side, precentral gyrus, motor cortex. It's affecting the area that controls facial muscles. And so then all of a sudden the right side of the face is droopy. We've seen, you'll see that, you'll run into that with patients. Post-stroke, they have a droopy right side, or they have a droopy left side. That means that the right precentral gyrus is where the stroke and where the tumor happened. Question? Okay. Pons. So the pons, again, this is all review. We're going through a lot of review. Don't worry. We'll get caught up. If we don't finish today, we'll finish next week. The pons relay signals from the cerebrum to the cerebellum. And these are more autonomic functions because they're brainstem, so they're further down. They're towards the tail, or they're rostral. Sleeping, hearing, equilibrium, taste, eye movements, respiration, swallowing, bladder control, posture. I mean, your posture is really an autonomic function. You can train it so that you're not slouchy, but for the most part, you just kind of do what feels comfortable, right? Cerebellum. The cerebellum has right and left hemispheres. It's connected by this structure known as the vermis. It has gyri, which we call folia, and it has sulci, which we call grooves. And it involves a lot of muscle coordination. So trauma to or injury to the cerebellum, which is the back of the head, below the occipital lobe. Someone who falls, smacks the back of their head, and sees stars. And obviously it was the occipital lobe that received the trauma. And we'll talk about this coup contra coup injury that takes place there. But very close to that is the cerebellum. So could they stand up and be dizzy, disoriented, and lose muscle control? Absolutely. Okay. So there's a lot of neurons here. More than half of all the neurons in the brain are packaged in the cerebellum. But it accounts for less than 10% of the total brain volume. Just some structures that are typically associated with it. If you cut it like in 201 lab, if you remember, you cut it down the middle, you do a cross section, you see this architecture showing the arbor vitae, right? That's the white matter that looks like a tree, and it literally translates as tree of life. But the cerebellum basically sits just above the fourth ventricle. Okay, then last structure that we're going to cover as we move through this review section is this medulla oblongata. This is basically the lowest portion of the spinal cord. A lot of autonomic centers are here, like cardiac centers that adjust the force and the rate of heartbeat. More reflex centers, things for swallowing and salivation and moving the head and the tongue. Also, your state of arousal, whether you're kind of paying attention to lecture or not, a lot of that has to do with activity in the medulla oblongata. The bottom of the brainstem is the older form of capital punishment of death by hanging. So it was to snap the brainstem at the medulla oblongata. It wasn't actually to asphyxiate or suffocate. It was designed to snap the brainstem at the medulla oblongata so you would stop the heart immediately. It was considered to be a very humane form of capital punishment, right? If there is such a way to put those two terms in the same sentence, right, and it not be an oxymoron. More modern day, military snipers are trained to aim right here at basically the base of the neck, right, at the medulla oblongata. And that's the one shot, one kill that's supposed to be very humane because it stops the heart immediately. All right, so the autonomic nervous system. It's an intricate network that controls many of the functions within our bodies. We've got our sympathetic division on the left. We have our parasympathetic division on the right. It controls all these vital organs that you see down the middle of this chart. And any lesion, any trauma, any pathology that's associated with them is going to cause major ramifications in your patient population. Okay? So just a setup to get us ready for some of the diseases that we're going to talk about today. Okay, you guys ready? So that was all review, just to get us kind of, dialed in. So just a quick reminder on our meninges and our ventricles, and let's talk about cerebral edema. So who can describe what cerebral edema is? Just off the cuff, what is it? Swell. Swelling of the brain. It's swelling of the parenchymal tissue of the brain. The word parenchymal just means functional tissue in that organ. So you get fluid that's accumulating in the brain. This is the lower picture. The bottom picture is showing cerebral edema. The top picture is comparing it to hydrocephalus, which is an increase in the production of cerebral spinal fluid. That top picture is an end-on view, an AP view, an anterior-posterior view, down the two lateral ventricles, and they're huge. These are the two lateral ventricles, so these are completely swollen. We'll come back to hydrocephalus in a second, but hydrocephalus is a combination of two challenges. One is too much production of cerebral spinal fluid, and secondly is not enough drainage. Now, you're not removing it out of the circulation of the ventricular system. And the second is really the major problem, is most commonly when the drainage gets backed up and you get an accumulation of cerebral spinal fluid, that's when you have this hydrocephalus. And hydrocephalus literally means water on the head. It's an old term, okay? Whereas cerebral edema is like fluid in the brain instead of on. You with me? You're like, why is it on? Well, if you think about the ventricular system and the circulation, the brain is actually kind of floating in fluid. And so it kind of makes sense that it's bathed with fluid. So with cerebral edema, this is the midline. This is the patient's right side. This is the patient's left side. This is the midline, and there's a lesion right here. You guys see this lesion right here, this mass? And it's causing an increase in the left side of the brain. It's the patient's facing you. Here is the two lateral ventricles compared to the lateral ventricles here. And what I want you to be able to appreciate is, do you see this rightward shift? The patient's right side, there's a rightward shift because this is swollen, so it's pushing the brain to the right side. Okay, so there's a rightward shift that's happening because that tissue is swollen and it's checked by a skull cap. So it can't swell and go anywhere because it's pushing, it's this side, it's pushing up against the side of the skull, and so it takes the midline and pushes it this way. A lot of pressure, headaches, very, very uncomfortable. Two major causes of this, of cerebral edema, either vasogenic or cytotoxic. And vasogenic is when the blood-brain barrier is disrupted and the fluid leaks in. A lot of times this is caused by inflammation in the brain or tumors. Tumors will do this. And cytotoxic. Cytotoxic is when there's an increase in fluid that's secondary to some sort of toxin contamination of the central nervous system. And so this could be that a neuron or glial cells are either ischemic or hypoxic due to a toxin injury or an infection that's taking place in the brain. So the vasogenic, so this is an image of a tumor, and this is from the top down. So what you're seeing here is this is the midline shift. You can appreciate very nicely. Midline shift, so the lesion is over on the left side. This is a contrast MRI. So the tumor is right here. You can appreciate this tumor mass. And this is all of the cerebral edema, all of this fluid that's in this patient's left hemisphere. And you can really appreciate the midline shift. Here are the eyeballs up top. This is the right side, this is the left side. Can you guys see that? So this was my late mother's contrast MRI of her brain tumor. So this was a few years ago. She actually didn't pass away from this. We took her to Barrows in Phoenix, got the tumor removed, everything went great. However, this tumor came, this was a secondary metastatic tumor. It came from the lungs. So she actually passed away from lung cancer. And this is how we discovered it, is she started acting really weird. It wasn't herself, driving, she drove horrible to begin with, but it was like worse than normal, okay? Yeah, so we got her treated. She was much more comfortable afterwards. And then for the chemotherapy, she just didn't survive the chemotherapy to treat the lung cancer. Non-smoker. It was a small cell carcinoma of the lungs, and it took her in like 6 months. It was about 6 months from diagnosis to when she passed. And this was like the first 2 months as we were dealing with this particular situation. Okay, so cerebral edema. I know that this is resonating with lots of you because cancer affects a lot of our families. Okay, and so understanding what's going on and just having some of this insight and this knowledge. Sometimes it's nice to know, and sometimes it's horrible, right? Sometimes it's horrible to know what you know, and then you freak yourselves out. Okay, so you gotta take that information as best you can and learn how to process it. If this is not a family member, okay, so don't worry, this was not a family. So cerebral edema. This isn't mom. That would be, I think, disrespectful. Right? I didn't do an autopsy on my own mother. That would be weird. Okay. So, but this is from a textbook. This is showing cerebral edema post-mortem. And what I want you to be able to appreciate is the flattening of the gyri as they basically push up against the skull cap. Okay. And in talking with mom, during this phase, I mean, the headaches were horrible. Okay. And as soon as that tumor went away, significant relief. Okay? And she started acting like herself again, which was nice. We consulted with a lot of great experts, not just at Barrow, but I have a number of friends across the country, neurosurgeons and cancer docs that are like my old college roommate's an oncologist. And so if you're ever walking patients through end-of-life decisions about brain cancer, brain tumors, so we actually thought it was what Kane passed away. At first we thought it was a glioblastoma, but it's not. It's clearly not a glioblastoma because there's very well-defined borders. You see that? You can see the mass. They went in and they surgically removed this, and then they used gamma radiation to treat that socket, that empty space. Great outcomes. And her personality returned like within a week. She was back to normal. And so when she passed on hospice, like she was mom. Like she remembered who we were. And that's kind of the most difficult thing at the end of life with brain cancer or with some of these dementias that we're going to talk about at the end of the lecture if we get to it today. If you have family members that are wrestling with Alzheimer's or a form of dementia, the most challenging thing is when they stop being grandpa or grandma. Like they don't remember who their loved ones are, they don't remember your name, they don't remember what happened, they don't remember like your 13th birthday, or your 16th birthday or whatever it was that was special. Those are really, really tough circumstances. Okay? So again, I'm only saying these kinds of things. This is all personal stuff, but a lot of you are going to be in the medical profession. This is the kind of stuff you're going to have to figure out how to walk through, okay? And be able to walk your patients through it, because that's what they're going to really need you for. I mean, they need you to help them, but more importantly, they need you to care. And that's probably why you're going into the field that you're going into. Okay, so along the lines of caring, okay? So this is a case that I've been following for years. Back like in 2013 is when I first found out about it. And I'm going to tell you right now, it doesn't have a great ending. Okay? I'm just going to tell you right now. And I double checked it. I looked last year, and then I looked again, and there was some information. Sometimes you don't know, fake news. Fake news is a real thing, and so you have to be a little careful about what news you take. So I waited a little while before I updated what the fate is of this little girl. But I want to walk you through the case, and there were some positive things that took place along the way. Okay? Yes, sir.
So just to make clear, so with hydrocephalus, the brain isn't swollen. It's just the right?
I can barely hear you, but I think your question was with hydrocephalus, the brain tissue itself isn't swollen.
Yeah.
Yes, that's correct. It's the compartments within the brain that swell with hydrocephalus. Okay? So this little girl's name, Runa. At 18 months, you can see her here with her mother. Hydrocephalus, if you Google it, you see all these Google pictures, right? And a lot of us in the Western world think that some of these things, we deal more with brain cancer, glioblastomas, tumors that come from secondary sites, whether it's from the liver or from the pancreas, or it comes from the lung, like it did with my mom. But these kinds of issues are still happening mostly outside of the United States. Because if you have a baby that presents with early forms of hydrocephalus, we usually treat immediately in the States. We have those resources to do that. But there's a lot of places. I mean, some of you might be looking into international medicine, and the environment is very different than it is in the States. Okay, so this is extremely rare in the United States, but it's much more common outside of the United States. So this is in India, okay, and this was covered by CNN at first. So she had hydrocephalus, a blockage of the cerebral spinal fluid being drained, and her head grew to a circumference of 94 centimeters, okay, and because it's not in inches for Americans, it's about triple the size of the normal circumference of a baby's head at her age, at 18 months. Father was a bricklayer. He made $3 a day. That's what he made. Okay, $3 US a day. And they had a 2-room hut that they took care of her for a year and a half, not knowing what was wrong. They're obviously not super educated. They haven't seen these slides, don't know if they have internet, so they can't even watch my lectures. Okay? That's very common outside of the United States, folks. Okay? So, in the springtime, after this was publicized, there were 2 students about your ages from Norway, and bless you, and they went to actually do a journal interview on this particular case. Came back, set up a crowdfunding source, and in about 6 months they raised $60,000 US, which was about 3 times the amount necessary for the actual surgery, okay, that needed to take place. Okay, so here's how bad it got. Okay, her eyes are actually open. You just can't really tell. Okay, look at this poor little thing, right? And this is the day after surgery. Okay, this is the day after surgery. Those are just the volunteer hospital workers there in camos with machine guns. Right? This is very common outside the United States, folks. You go to hospital settings and it's just, they're military states. They're not just police officers or security guards, or they're like the actual military of the country is there, right? So that's very normal. This went really well. This is her as it came down, the swelling. Now, she was 18 months old, and this is back in 2013, okay, 2018 now. Last summer, she actually passed away. She had a number of additional surgeries that were necessary. They corrected the first issue. Usually they put in a shunt, and they shunted, but because it had gone so long, she wasn't walking, she wasn't speaking, she was having trouble eating. They were doing additional surgeries to try to correct those events or those pathologies. And in about, well, not this June of 17, so not this past June, but the June prior is when she passed. But you know, she had a little bit more time with her family. It's nice that the Western world found out about it, was able to fund it. We learned a lot. These were two students that made a difference on a crowdfunding site on an issue that still happens today. Okay? All right. You guys okay? It's kind of a heavy lecture. There's a lot. The brain is like a lot with the brain, right? It kind of is a big deal. You only have one of them. There's a lot that can go wrong. You guys with me? Okay? You guys need a break? Okay. All right. Let's talk about brain herniation. So, if you have increased intracranial pressure in the brain, and that could be through trauma, that could be through a lesion, a tumor, that could be through blood pressure going up. Well, there's areas that's very common for herniations to take place, where the pressure gets big and then there's a bulge that happens. And you think of a hernia kind of like, you have an old garden hose and it's connected to the spigot, but it's got like a nozzle on the end, and you turn it on and the casing's wearing out. There might be an area where the whole hose kind of bulges under pressure. Does that make sense? So that's what we have here, is an increase in intracranial pressure. So it could be due to an infarct or damage that takes place in the brain, and then that tissue is weakened. But there are really kind of three main types, and you can see the pictures here pointing to where they take place. Subfalcine, and then we've got the uncinate, and then we have the tonsillar herniation, which is down here at the level of the brainstem. The uncinate is kind of in the medial aspect. The subfalcine is the most common, which is at sort of the top of the brain, just on the superior portions of the lateral ventricle, right next to where the hemispheres actually separate. And then at the level of the tonsillar, which is at the brainstem, you can see when there's a tonsillar hemorrhage, or herniation rather, excuse me, that you can get a shift in the brainstem. And in some cases, those tonsillar herniations can actually lead to what's called a Durrett hemorrhage. And so the tonsillar can actually progress into a Durrett hemorrhage. The Durrett hemorrhage was actually named by its discoverer, Henry Durrett. And it's an area where you get some small bleeding that happens at the level of the brainstem. Typically, it's the midbrain and the pons. So let's transition a little bit into stroke. We've been talking a lot about the parenchymal tissue of the brain. That's the functional tissue of the brain, where there's a trauma or injury, or whether it's a tumor mass. And then we kind of talked about an infarct, where we've got a blockage of blood flow and it can create a lesion. But let's kind of unpack cerebral vascular stroke a little bit in more detail. So there's really kind of three processes that can take place here, or lead to a cerebral vascular event. This is affectionately referred to as stroke. And we'll talk a little bit about like mini strokes. Okay, Grandpa had a mini stroke. What the heck is that? Okay. So There's thrombolic occlusion or embolic occlusion, and then you can just rupture the vessel altogether. So a thrombotic occlusion is where the blood is clotted, thrombosis. And so if you have the carotid vasculature that goes up to feed the brain, it bifurcates into an internal and external carotid, if you remember from 202. And that perfuses the microvasculature of the brain itself, and they get into very small diameter vessels. And around the top of the brain, we have what's called that circle of Willis, and we'll show that here in a second on one of these slides. There is a lot of redundancy in the circulation in the brain because it's so important. That means if blood flow is low to one area, it might be picked up by another area. But if the blood clots quickly and it eliminates blood flow to a certain part of the brain, you're going to have trauma or damage to that brain tissue. Blood clotting or thrombus. Embolic means that something gets lodged into the lumen of the blood vessel and it prevents distal blood flow. That's embolic. Excuse me. The embolism could be a piece of clot that was from somewhere else that broke off and moved downstream and they got stuck. Usually it's going to get stuck if the blood vessel actually is narrow because it has disease, right? And we'll talk about more of the atherosclerotic disease at the last portion of this class at the end of the semester. But atherosclerotic disease, where you get narrowing of the vasculature due to lipid accumulation and plaque formation, that happens ubiquitously throughout the entire bloodstream or the vascular supply, not just in certain locations. It's more exaggerated in certain locations, but it's happening everywhere. Okay? And then the last one is vessel rupture. So the vessel itself could be weakened, either due to age or due to a genetic disease. And as that vessel wall is weakened, if it's pressurized, it can actually just give way. And then you have a massive hemorrhage out of the vascular system and into the surrounding tissue. Okay? So if we've got different types of ischemias that we can characterize, the first one up is global cerebral ischemia. So this is usually widespread ischemia or hypoxic injury. These are patients that are suffering from a systolic pressure that's less than 50 millimeters of mercury. So when would you see that? When would you expect to see that? Blood pressure is down below 50. What's normal pressures? 120 over 80-ish, right? So 50, systolic, the bigger number, that's pretty low. That's less than half. When would you see that? What's that? Not just in old age. They'd probably be in cardiac arrest. When would a patient's blood pressure be that low potentially? Shock? Okay. So usually trauma, and they've lost a large amount of blood volume, and they're going through shock. Okay? So the clinical outcomes are not so great here. This would be considered severe hypotension, and if somebody was older at these levels, they would not feel very well. They would probably go see their doctor well before it got to 50 systolic pressure. But hypovolemic shock, if they get in a motorcycle accident, the most common place that I would see it, and car accidents, trauma, they would lose large amounts of blood volume in a very small amount of time. And the brain itself, cells begin to die after 4 to 6 minutes of no blood flow. You lose consciousness after about 10 seconds of no blood flow, and it's a protective mechanism. Blood flow is ceased for 10 seconds, you lose consciousness, you fall over, now you're laying on the floor. It's easier for blood to get to your brain when it comes back on, right? But 4 to 6 minutes, about 5 minutes plus or minus a minute, is all your brain cells can handle of no blood flow, and then you start losing it. So that would be global cerebral ischemia, the whole brain, okay? You bring patients back. If anybody's EMT certified or paramedic, right? That 5 minutes is that's a fast response time. So if you can revive somebody under that 5-minute mark, there is the possibility that if you reestablish blood flow, they may not have permanent brain damage. Okay? If it's 10 minutes, 15 minutes, they'll come back potentially, but they might have lost certain functions. Focal ischemia. This is typically due to an infarct, like what we see with the heart. And so the collateral flow, like we talked about, which is this circle of Willis, we've got a lot of redundant circulation that takes place, but if you block something long enough and aggressively enough, you will minimize blood flow to the brain. And beyond 5 minutes, if it's 10, 15, 20 minutes, you'll get a scar that forms because of the permanent damage, the permanent trauma. How do the occlusions take place? Usually thrombosis or embolism. Thrombosis is the clotting of blood, and then embolism is when something breaks off and gets lodged in the lumen of that vascular supply. So here you can appreciate a local infarct. It's not widespread, it's just in one area, the right hemisphere of this patient. If you're looking down the midline, this is these are the lateral ventricles here. Here's the third ventricle at the bottom. In this area right here that's scarred, or what kind of necrosis takes place here? Liquefactive necrosis. So I get a lot of questions in my office hours. Can you give me an example of what a type of review question? You say that these tests are cumulative. So how are you going to ask these questions? You're going to take a test question off the old exam, one that everybody missed, and put that back on the next exam? No, I'm not going to do it that way. I'm going to do it like this, right? Like what we just said. Where if we talk about this, I could ask about this infarct, and if the patient survives it and has clinical sequela later on, what type of necrotic tissue is going to form post-stroke in the brain? And you guys just told me it was accurately liquefactive necrosis. That's a perfect example. I don't want you to forget that stuff. You recalled it right away. You weren't even studying it. Does that make sense? So if you know it, you'll probably know it on the exam. If you stop working with the material, it may be gone. So just stay with the material. But you guys all pretty much knew that answer right like that. You didn't have to look it up. Okay? So that's good. That means that you remember it, and you know, newsflash, you just learned something, right? And you retained it, because the exam's over, and you guys just gave me that exam answer, which is perfect. Okay? All right, so let's talk about transient ischemic attacks. And as we finish up the TIAs and infarctions, we'll take a little bit of a break. So a transient ischemic attack, these are like, bless you, these are what people refer to as mini strokes, okay? Or in some cases they talk about them as mild strokes, not a full-blown stroke. Grandpa just had a mini stroke. The clinical term is a TIA, or a transient ischemic attack. So there is a temporary loss of blood flow. That's the important piece here, is that blood flow is reestablished. But the dangerous thing is they're typically very predictive for stroke. Very predictive for stroke. Meaning, if a patient is having a transient ischemic attack, which is like a acute, temporary, that doesn't stay, stroke-like complication, something's not right, and they should probably have it investigated. Because a lot of times patients that have TIAs have a stroke later on if they don't correct anything. It's like the check engine light just went on. You guys with me? Some of you are like, don't say that. Okay? But what if it goes off, Dr. Keller? I don't know. I'm not a mechanic, but if that light goes on, I think you should probably go look at it. Okay? So the TIAs are like the check engine light, and it means that something's not right and your body's giving you that signal. So here in these images, and then I'll get to your question, you can see figure 1, which is the left image. This is a normal artery. You can appreciate, this is actually the carotid. So the carotid towards the bottom is the common carotid, and then it bifurcates into the internal and the external carotid. and it's wide open. So you inject this with a radiopaque dye and you take an x-ray, and you can see where the dye fills the lumen of the vasculature, and you can measure that. You can kind of see that the dye flows nicely, so there's no blockage. In contrast, if you look at the right image, you can see post-injection, post-radiopaque injection, you can see some narrowing that takes place post-bifurcation. And that's actually giving you a clue of where those troubled spots are, of where a thrombotic event could happen, where the blood clot in that narrowed area, or an embolic event could happen, where something could break off and get stuck in that small opening. You guys with me? And so these are angiograms that are taken. They're non-invasive. It's like taking an x-ray, but you inject a contrast agent before you do it, and you get a picture to see how open or closed the vasculature is. Very, very similar technology that's used to look at brain circulation as is used to look at coronary circulation. Okay? There was a question.
So this is like angina for the heart, but just for the brain?
It is like angina for the heart, but for the brain. That's actually a good analogy. Yep. Angina just means, it literally translates to a strangling feeling in the chest. Right? It's faster to say angina. Chest pain. And so chest pain for patients is usually an indication that something's not right. Now, if the patient decides to listen to that, they might be able to get help, early enough. The challenge with the big differences, though, between heart and brain is a lot of times the angina, we'll talk about this at the end of the semester, the angina, you can actually see it happen and manifest itself even earlier than TIAs. Because a lot of times, like the brain is just operational. You could do some brain exercises, but really blood flow to the brain doesn't really increase that much. Whereas if you climb a flight of stairs, you might initiate chest pain upon exercise, and that's a certain type of angina, versus chest pain at rest. So a lot of patients at rest are asymptomatic. They climb the stairs to go to their second bedroom or their hobby room upstairs, and they have the chest pain. And they're like, well, it was just because I was exercising, I won't do that anymore. And then the thing is getting worse and worse and worse, and they don't realize it. Does that make sense? So the chest pain, a lot of times we get signs even earlier than we get with TIAs. But that has actually a pretty good analogy. So if you get an infarction, what does this look like? Well, so these are histology examples of central nervous system, cerebral tissue. Up top, you can kind of appreciate this sort of watermark, and this is a gliosis. So this is the scar in the brain right here, and you can see normal tissue here, and this is kind of where this imprint almost looks like someone put a glass of water on a magazine, and this is the watermark to the left. So that's the scar that's taking place in panel A. The upper right, which is panel C, you've got a blow up at higher magnification. So this right here is this structure right here. So this is in higher magnification. And as we zoom in, we can see that there's infiltration in that cerebral infarct by the first responding cells in an inflammatory event, which are neutrophils. Perfect review question. You guys nailed it, right? Liquefacted necrosis, neutrophils are the first ones that come in. That histology image, these are all neutrophil infiltrates that aren't supposed to be there. But they're there because you have an inflammatory event. And then panel D, right down here, panel D, you can see that those cells are a little bit different and they've changed. This is after 10 days of the infarction, and now we have the presence of what type of cells do you think that are there? They would be macrophages if they're outside the central nervous system. That would not be incorrect. That would be correct. But a more accurate description of those macrophages in the central nervous system would be which type of glial cells? The microglial cells. Okay? So on the exam, I won't try to trick you with macrophage and microglia. You'll be like, they're kind of the same thing, and I thought the microglia were the central nervous system. Yes, and if I make a mistake, that's a definite challenge that you should ask for that question. So I will not make it confusing. If I do on accident, you should come challenge me on that, okay? Because that was not an incorrect answer, macrophage, but the most correct answer would be the microglia, okay? All right, and then how do we treat these? And then we're going to take a break right after this slide. So we can do this pharmaceutically, or we can do this through endovascular therapies. And pharmaceutical treatment of the cerebral vasculature typically involves trying to prevent the blood from clotting. Okay? So you keep the blood flowing. So if you know that you have a patient that's at risk for a stroke, you may put them on some type of antiplatelet therapy or an anticoagulant. So they might be over-the-counter on aspirin. It's a great antiplatelet. They might be on a Plavix or a Versantine, which is actually a prescription strength. They might be on something stronger, which would be Coumadin. And Coumadin is an anticoagulant that really is somewhat rather dangerous if you're not careful with how you're the doses that you're taking and your activity levels. So people that are on Coumadin usually are restricted from a lot of physical activity. If they fall, they could actually internally bleed. Okay. Folks that are on a lot of Plavix or aspirin, and maybe you've seen grandma that take an aspirin a day, they bruise very easily. Like if they bump up against the cabinet door, they get a bruise. But if they fall, they're probably not going to bleed out internally. Whereas with Coumadin, you would worry about that. So you usually don't put an elderly patient who's unstable on Coumadin, who's mobile, because it's kind of a very dangerous combination. Okay, so that's pharmaceutical treatment. Endovascular treatment. So there's a number of different solutions in the endovascular world. Back to our imaging, you can see this narrowing right here. We can access through either the neck or from the arm, or you can actually come from the leg, and you can come up into the neck. You deliver on a catheter a crushed down stent to reopen blood flow, and you can kind of appreciate the sequence of these images here. Here's the narrowed vessel. The catheter is inserted through the lumen. The stent is crushed down on a balloon. The balloon is inflated, opens up the stent, the balloon is deflated, the catheter is removed, and it reestablishes blood flow. Okay? There's all sorts of different versions of stents now. There's drug-eluting stents. Okay? Before we actually left the stent, we would just use a balloon angioplasty. We'd come in and open up the balloon, deflate the balloon, push the lesion out of the way, right? Usually we crack the plaque, and then the re-narrowing rate was pretty aggressive, so we started putting stents after we inflated the balloon, and then the re-narrowing rate was less prevalent, but it still happened. So now we actually coat these stents with an anti-proliferative, so that the re-narrowing rate has a sink that it has to go against. It's battling this anti-proliferative drug that's left behind on the stent coating. Okay? You kind of appreciate the two internal and external carotid side by side. Here is the narrowing that takes place when it's diseased, and this is where we would want to open it back up. The old methods of doing this were carotid endarterectomies, where patients, and if you run into patients that probably would be in their 80s now. So if you have a grandparent or you know of individuals in their 80s, maybe in the late 80s, we haven't done carotid endarterectomies for a while. They would surgically open up the neck, and so there's a scar about like that, about a 5 to 6 inch scar on the side of the neck that had the endarterectomy. They would dissect down to the level of the carotid, and they would tie it off, cut it out, and sew in a replacement. Okay? That was the old way of doing it. It's actually the old way of doing coronary artery bypass. They crack the chest and do the same thing. So we moved, so the number of open procedures, the surgical open procedures, is on the decrease. and the number of endovascular procedures where you come in with a device through either a vessel in the arm or a vessel in the neck or a vessel in the leg, and then under image guidance, right, with your, mad Xbox skills, you actually move the wire and the device into place. You pull a ripcord, you push a button, the device opens up, you back it out. That's medicine today. Pretty crazy, right? Got a grad student in the back that's working on endovascular therapies for aneurysms of the vasculature, where their technology is going in with a catheter and injecting a polymer that actually fills the void space and prevents it from rupturing. So a lot of the technologies are moving away from surgical approaches and moving more towards endovascular approaches. Okay? Questions? Yeah?
Can stents become dislodged or perforate the artery?
Pardon?
Can stents become dislodged or perforate the artery?
Yeah, absolutely. It happens on occasion, unfortunately. Yep. So the question is, can the stent become dislodged? Can it perforate the artery? Yes. The other thing, too, that can happen is when you do this and you smash this out of the way, you're at risk of dislodging a lot of this cracked plaque and sending it up into the head. So a lot of companies now have built these filter devices where you come in here first, you put a giant filter, then you do your endovascular work upstream, and then anything that gets dislodged goes downstream and gets caught by the filter, and then you collapse the filter and you pull the filter out and take a look, and you're like, oh man, look at all the crap that we caught and avoided another stroke up in the superior part of the head. Pretty cool tech out there. Okay, yeah, last question, then let's take a little break.
What's that plaque made out of?
What's the plaque made out of? That's a great question. So we're going to go into that more in the last section, but the answer to your question is it's a inflammatory event that takes place in the wall of the blood vessel. And so what accumulates there is scar tissue, and then you get macrophages that infiltrate, and there's calcium deposits and lipid deposits, and then the macrophages digest the lipids and they become what we call foam cells. So it's a scar that's consisting of calcium and lipid or fat. And because of the calcium, they can become very hard and non-compliant, meaning they're stiff. And so when you open them up with a balloon or with a stent, they crack, they fracture, because they're made of calcium, hardened calcium. So when we get these vessels on a pretty regular basis in the lab from cadavers, and we'll get a stretch of a vessel and put it down on the bench top and take, like a straight edge razor blade that you get at like Ace Hardware, cut this way or cut this way, and depending upon the extent of the atherosclerosis and the calcium deposition, you'll hear it crunch. You'll hear it go. And then you look at your blade and it's like jagged now. It's like cutting through stone. In fact, if you go to BB Learn, you go to the announcements, you scroll down, there's an old picture from an old semester of a vessel filleted open with pins, and you can see the inside plaque on the surface of that vessel. And I left it there so that when I lecture at the end, I can point to it, but since you asked now, you can look at it early. Okay? Go grab a snack and take a look at it. All right, we'll take a break. Okay, 5 minute break.